All right, we are live. Hi, everyone. Good morning. We're going to get started in a couple of minutes here. Nice to see everyone this morning. Hi, Yvette. Nice to see you. Hi, Jane. Good to see some sun representation today. This is going to be a really helpful session for sons. Hi, Patty. Nice to see you. We just had our internal sustainability meeting this morning to get ready for everybody. I guess 2 weeks from now is when we have our next chat with you. And just so everyone knows, it's going to be a lot of really important information on this webinar about the California Bridge data collection process and how you can use it, and we are recording it. So anything you'd like to go back to, that will be accessible. But this is a great chance to ask questions. Anything on your mind, you can go ahead and fill in now. And if you want to take a moment while we're getting started to put your name into the chat with what hospital you are affiliated with, we would love to see who's here. Maybe our panelists can get started just using the chat to tell us who you are and where you are joining us from. We will get started right on the hour here. Great. Oh, wonderful, Troy. One of our St. Joe's, Providence St. Joseph's Hospitals, BC. Great. San Dimas Community Hospital. Awesome. Hi, Sky. Morning. Hi, Patty. Good morning. You know, it looks like if you want to share something that everyone will see, you're going to go to panelists and attendees. It's totally okay. Oh, great. Tehachapi Valley. Good. Adventist representation. It is totally okay to ask a question just to the panelists, but if you do want to share something throughout the course of this that might be applicable to others, you're just going to make sure under the Zoom chat where it says to that you're clicking to panelists and attendees. So I'll go ahead and test mine out. There you go. Yeah, no problem. You'd think we all would know Zoom like the back of our hands, and even people who use it every day, I find we're still forgetting or doing things wrong or, you know, talking when we're on mute. We all thought that you're on mute would be the theme of 2020, but it seems to have bled into this year as well. Thanks, BC. All right, we're getting started in about 3 minutes here. If anyone has anything on their mind that they want to get started by asking, anything, if you've participated in our data collection process before, anything you're particularly looking to know, can share that now, just so we make sure all your questions get answered ahead of time. Otherwise, there'll be plenty of opportunity for Q&A as we go. Hi, Jake. Nice to see you this morning. Thanks for hanging in here with us. All right, friends, if you want to use the chat as you're hopping on, make sure you pick panelists and attendees, and we will get started in about a minute or two. Yvette is wondering, just drawing BC and Jen and John's attention as well. Yvette is asking what metrics are people pulling to collect the 5150 data. I believe we're going to address that. Jen, is that right? Are we going to speak to that? Yeah, we will chat about that in the slides. Yeah, we've gotten that question from a lot of people, Yvette. That's you are not the only person with that question. So we did plan this presentation in response to a lot of the questions that we've gotten from hospitals. All right, friends, we are on the hour, so we will go ahead and get started in about 1 minute. We know that Zoom time usually means about 5 minutes after, but you know, we do try to stay stay on task around here, since we know everyone has a lot of different requirements and things going on at your hospital. So we'll make sure we get everything in so that we can get everybody back to work with this knowledge. So I'm going to go ahead and pass it over to our presenters, Jen and BC, to get started. And friends, just know for probably the next 3 or 4 minutes or so, we will have people popping on pretty rapidly. So go ahead and get started. And thank you everyone for joining us today.
Awesome. Well, welcome everybody. This is BC. I go by BC for all of my friends out there. My formal name is Bharath Chakravarthy. I work at UC Irvine. I've been involved with the Bridge program for several years now, and am in Orange County, California, where we've done some significant amount of work and have skinned our knees along the way. And I wanted to share some of those pains and successes with you. And specifically, Jen and I are going to be talking about measuring and communicating success. Jen, do you want to introduce yourself?
Yeah, hi everyone. I'm Jennifer Zhan. I am an emergency medicine physician in downtown Los Angeles and one of the regional directors for the California Bridge program in Southern California. I've met or chatted with a lot of you virtually, so it's nice to see your names again. And we are excited to share this information with you. I'm going to let BC get started, and we'll have a Q&A session at the end.
Awesome. Well, really the objectives of this talk, if you will, is really to understand the impact of California Bridge on our current sites. That goes without saying. We're going to have you guys be able to use the existing bridge tools that have been gone into all of the background work that many of the panelists that you see and people who aren't even on this call have worked tirelessly to help really focus your site into monthly data reporting and quarterly summaries. And it's really kind of killing two birds with one stone, and maybe even three, because as we kind of evolve into the next steps of the California Bridge program, funding obviously becomes a very key and integral part. And how do we sustain that funding? How do we use data to really help us sustain that funding? And how to have these discussions in expanding the program, and in really bending the ear of our C-suite. And so those might be the CFO, the CMO, the CEO of your hospital system. Objective number 3, we want participants to understand how to measure outcomes to improve care for underserved populations. I think one of the key things that we've found along the way are the challenging populations, the underserved populations, but mostly the highest risk populations. And we'll talk a little bit more about that. We want to really show you how to package your return on investment in a way that you could have an elevator conversation, again, with anyone, but specifically even a sit-down conversation as the time comes near to transitioning from the BHPP grant funding. So we started out with the California Bridge grant funding, and we moved to the BHPP grant funding, and now what? How do we sustain all of the measures that we made? How do we keep growing and doing the good work that all of you have done? Along the way, we're going to discuss the opioid honor roll. I think that honor roll really sits quite well with many of the folks. People like awards, and they like their hospitals getting awards. And so how do we leverage that honor roll? And really communicating success. How do we do that? And we're going to go all over all of these 6 objectives. This is a map that you guys have seen, and it always impresses me to see all of these dots on this map. I mean, since 2019 and even earlier, the seeds of these X's or these crosses, if you will, on our map really took root and have grown. And now you can honestly, just in one quick visual view, see all the 208 hospitals that have implemented the California Bridge model and all of the impact this program has had. The life-changing effects, not only at the hospital level, but really at the patient level, at the community level. And it is extremely gratifying to be part of this organization and to try to make sure we can continue to do this wonderful work. This is just a quick disclaimer here. It's really saying the California Bridge Program is a program of the Public Health Institute. And the Public Health Institute, as you know, promotes health, well-being, and quality of life for people throughout California, across the nation, across the world. So just wanted to make sure everyone knew there's so many different entities involved. Even in our world in Orange County, California, we certainly have a number of different collaboratives, and some of them are integrally involved with the Bridge program, and others are tangentially involved, but it is always good to give credit where credit is due. We're going to move on to kind of the impact of the California Bridge program as we kind of go down these slides. Well, these are data that are from the first year. These are cumulative totals across all reporting sites, and these sites were 56 sites from April 2019 to September 2020. Look at all of the sun encounters, 37,230 sun encounters. Each one of these encounters, as you know, is super valuable. As much as things have changed during the pandemic and we've moved to different models of care and different models of reaching out, it is this connection that really makes a difference. Amongst all of these patients that had these encounters, we know many of them, almost half have been identified with opioid use disorder. So that's phenomenal in and of itself. And over 7,000 prescriptions for MAT. And so that is absolutely phenomenal over that short period of time with 56 hospitals. Now we've expanded tremendously, and that impact is only going to be much larger. Speaking of much larger, these are cumulative totals across California Bridge sites, over 86 sites. The time frame here is from April 2019 to March 2021, so a little bit longer of a time frame. During this time frame, we've had 48,000 sun encounters, 24,000 patients who are identified with OUD, and again, 10,000 plus encounters where MAT was prescribed or administered. So over a slightly larger period of time, again, more hospitals or more sites reporting, that impact has grown, and that is significant because as we keep moving and evolving, we really want to show, number one, at a local level, how much of an impact that we've had, but number two, at an institutional level, so California Bridge and PHI, we are part of that organization, and showing data makes really will impact how we've shown how those resources have been used and the number of patients that have actually been affected. This is our, people always ask about reporting and data, and I know I, for one, although we're doing very good work across the board, the reporting part is and can be a thorn in people's side. So what we wanted to do and what the Bridge program really has done is simplified that. There's a QR scanner code that takes you directly to this website and really kind of focuses in on how and what needs to be reported. Of course, your regional directors and the administrators at the Bridge program can answer any of these questions, but at any given moment, data is really important. Having that data in hand for yourself and for reporting and requirements is also equally important. There may be some changes in how this data and where this data goes, and that there's more to that later. But really, we wanted to simplify how this data is accessed. Some of these metrics that we think are extremely important as you create, in air quotes, your dog and pony show. So what we're doing here at UCI and in Orange County, we're creating a simple, small slide deck, very similar to the ones we have right here, using local and statewide data. And so what do we think is important amongst these metrics? And so number one, the number of ED hospital encounters where a patient was seen by a Sun behavioral health specialist. That's really, really important. Those are overall numbers. Number two, the number of ED hospital encounters with MAT and BUP administered, kind of that, that infographic that we saw earlier. Number three, the number of ED hospital encounters where a patient was given an overdose diagnosis. That's equally important. So all of these data metrics are really important as you kind of formulate these slides or your talk to the people who are holding some purse strings so that you can continue your work. Number four, the number of ED hospital encounters with the diagnosis of OUD. And number five, the number of ED hospital encounters where a patient was served by a behavioral health counselor, a son, while on 5150. And we'll talk about how to kind of do that. Every hospital has a way to gather this 5150 data, and psychiatric patients who have also substance abuse issues, which many of our patients do. All right, moving on to data records and tools. We really are interested in keeping your data submission receipts. These are the receipts that you receive from the California Bridge program. Kind of keep those handy, tuck them away. We get a myriad of emails all the time. And I know spending time to organize information is half the battle, but boy, does it save you a ton of time down the road. But so, you know, if your inbox is set up in a way you can flag it with a specific color-coded flag, that's fantastic, but save these receipts. And similarly, I know we're sharing data to the mothership. We're sending data willingly, and a lot of our sites are sending them directly to the California Bridge program. But one thing to do is kind of maintaining some internal reporting worksheets. Why? Number one, it's right there in your hands. Not that the California Bridge program wouldn't be able to turn that around, give you that data almost within a several-day time period, but it's always there. So you have an account of the number of patients that you're seeing and the direct impact that you're having at your hospital site. So at any given moment, if you're stuck in an elevator with the chief medical officer or CFO, you could say, yeah, how is that program going? And you have that information because you have a running tally yourself. And then finally, we're always there as regional directors. Jen and I are just two of many regional directors, and we're always available. I share my mobile phone number with all of the people who I'm kind of directing. And so at any time, texting me or calling me, and if I don't know the answer, which is you know, some chunk of the time, I know how to get the answer, and certainly we will make sure we do everything possible to have that information, give that information to you so that you can use it effectively. Moving on to vulnerable populations. Now, this is extremely challenging. You know, I remember just looking back 2 years ago when we started this program at UC Irvine, the University of California, Irvine. This is an academic center, which is supposed to be in the forefront, leading the county, leading the region in making changes and positive changes. It was a challenge for us to implement an MAT program in a hospital system that I've worked in over 13 years, but it wasn't insurmountable. It means having the time and the energy and realizing that change takes time and energy. Similarly, so now we're at a stage where we have, our hospital has consistently received the opioid honor roll designation. We have patients giving us positive feedback, which we share with key stakeholders within the hospital and the county. We've made a tremendous amount of collaborative ties within our county, but we still struggle with these three sets of populations. So, you know, patients who don't have a home, the reentry population, and the high-risk OB population. They are very, very challenging. Each one of these populations have their own set of unique challenges, many of which overlap, but some of them are just their own set of unique challenges, which we're going to go over in just a second. So knowing what those challenges are, which are probably universal amongst all of our sites, but certainly knowing those challenges and then trying to address them with clear objectives and clear action items is important. So specifically speaking with patients who are homeless, who don't have homes, we all know this, right? Dual diagnosis goes hand in hand with substance abuse and mental health, and I think at a higher incidence with our patients without homes. So really being able to address some of those issues and having mental health hand in hand with your OUD. That doesn't mean that everything needs to line up absolutely perfectly for you to treat a patient for mental health or treat a patient for OUD. It just means that having a holistic view of their needs is absolutely important. Similarly, access to care is a huge, huge issue. Whether or not these patients have adequate insurance, which is also a challenge, is a separate issue. Getting to the hospital, getting to the clinic, thinking about telehealth type of interventions for patients without homes is absolutely challenging. Some patients have mobile phones and smartphones, others don't. So these folks are really looking for the basic necessities of life and the social determinants. So safety, food, shelter, those are the most important. And then only then can we start addressing some of these other issues, which are intertwined, obviously, with all of substance abuse and mental health. Specifically, having an ID is one of the things that we have had challenges with in Orange County. Many of these patients do not have IDs. Picking up prescriptions at their pharmacy, even if we're prescribing it to a pharmacy that's really close to them, is extremely challenging. Without an ID, many of our pharmacy sites won't deliver these medicines. So getting that addressed is important. Talking about the reentry population, again, another set of challenges. Really what we've had a difficult time is the jails themselves don't even know exactly what date they're going to be released and the time they're going to be released. So if you talk to the medical director of the jail, which we have an intimate relationship with, he specifically tells us we don't know when these patients are going to be released. We get a notification earlier in the morning, not even the day before, when they're going to be released. And so having that patient, that reentry patient, go back into the community and being exposed to perhaps some of the same pharmacologic and social risk factors without treatment and without that linkage, that bridge that we have formed over time is challenging. So that's one thing that certainly needs to be addressed. Reestablishing insurance goes hand in hand with that, right? So a lot of our patients in jail, most of them don't have insurance, right? And so when they come out, how do we reestablish insurance? Get them back on Medi-Cal or whatever insurance that they were on previously. How do we do that? That's a bigger conversation to have with your local Medi-Cal offices and your local Medi-Cal group. And then finally, life coaching. So it's not just knowing all of this, it's really these patients in jail have not taken care of themselves, if you will, for who knows how long, months, years. And so simple things like, where do I stay? Do I go back to my family? How do I reestablish a home residence? Where do I go? How do I get to see my correctional officer? All of those things seem fairly easy for people who have stable homes and who haven't been in jail, people like you and I, but it is absolutely difficult for those who have never done this for a year. remember, for a whole year or longer, these patients, these patients have been told where to go, where to be, when to eat, when to shower, all that kind of stuff, and that it's like having a 24/7 schedule, and now their schedule is completely free, and reestablishing themselves is extremely important. Our OB patients, I think, are also can also suffer from some of the same type of social determinants, not having a home, having dual diagnosis, and whatnot. But at the same time, what we've generally found is that there are limited providers, outpatient providers, willing to engage in the MAT process. So, and furthermore, most of the current paradigm in treating OB patients centers around methadone. There's absolutely nothing wrong with that. But I think as we think about expanding BUP and MAT in general, I think some of that is a cultural change with those OB providers that are out there. Similarly, in our neck of the woods, we do have family medicine who have, in our FQHC, really taken the lead in providing MAT and specifically buprenorphine for our high-risk OB patients. So one of the goals I think that we should have in providing care for these patients is expanding the number of MAT providers. So it's a slightly different focus from the other two groups, but expanding MAT providers. So that's a lot of academic detailing, that's talking, knowing the lay of the land in our community, and knowing approximately how many MAT providers are out there providing high-risk OB clinics, and seeing in which avenues and ways that you could actually accomplish this. So let's talk a little bit about solutions. We did just chat about some of the challenges, and so let's talk about potential opportunities and solutions. So one thing that I want to really stress is the fact that there's a lot here, right? We all have full-time jobs, and this work that we're doing sometimes overlaps with our full-time job, but a lot of times is more work, although very rewarding, does take time and does require help. So the one thing that I would say is really to tap into those resources that are already there. Do not try to reinvent the wheel. Using the existing resources that you have, the connections that you have, the collaboratives. For example, in Orange County, we have a number of different organizations and collaboratives that are doing some phenomenal work and doing it kind of independently and in parallel with a greater movement of the Safer RX OC collaborative. So we have an organization called the Be Well OC organization, and they have really been one of the thought leaders, especially when it comes to the reentry population and in bringing care. So working with those key stakeholders, becoming part of their organization, bouncing ideas off of them, and finding solutions that are mutual to both groups, and working towards them in a sustainable fashion with objectives that are obtainable are really important. One of them is just bringing, for example, for our patients without homes, is bringing care to them. Is it possible that we can work with the shelters or a shelter to start with and bring MAT to them? Of course it is. How do we do that? How do we make that work? And so having these discussions with the stakeholders at these shelters is extremely important. How do we address social determinants of health? Again, food, shelter, thinking about food insecurity, and how can we use those organizations, people, interested parties, and stakeholders, bringing them on board with you to use their ideas in helping address some of those issues. We spoke about not having a clear way to really reach out and connect with these patients. So is there a possibility to have an Obama phone? A phone where patients without, low-income patients or patients without homes can have, so that we can establish a rapport with them. So our substance use navigators and beyond have a way to get a hold of these patients. Of course, these patients can use it for whatever else they want. In fact, that would be fantastic. How do we establish an ID? An ID requires a home residence. So can we work with the shelters so that these patients can establish a home residence at the shelter? How do we then get them an ID with DMV or other places? These are challenges that are difficult, but working around this paradigm and understanding how we can do it, how we can actually accomplish this piece by piece, and working on it over a long haul. And I want to reference back to my several slides ago, where really we had a very challenging time even establishing MAT within our hospital 2 years ago. We've come a long ways. So if you're anywhere along that spectrum, you're doing great. This is MAT 2.0, maybe even like 3.0, and you can do it, but it is going to take time, and it's going to take your ability to really reach to those stakeholders and integrate small deliverable objectives that'll make you feel like you're getting things done and making a difference, so that you can check that off of your list as your scope kind of grows. With a reentry population, we spoke about this, really engaging the medical director at the jail, engaging perhaps even the parole officers. How do we keep in contact with these patients who are now released from jail, who are now reentering into society? How do we do that? Who's gonna, in our jail system, luckily, our patients mostly are getting prescriptions after they leave. But linking them up with the next steps is really important. Getting our substance use navigator to engage in that whole process, even though obviously our substance use navigator is employed by the University of California, Irvine, this is a bigger movement. And having that person or having a group of people interested in this world, so that we can really link them up with services, keeping them out of jail, out of using substances that might put them at risk for encountering the jail system is really important. Our next steps, and some of these we haven't quite even done yet, but these are just ideas. So our next steps is try to engage our parole officers. Is there a way that they can tip us off, if you will, if we've had some loss to follow up with our patients leaving? Can they tip us off and say, hey, we heard, this, is there a way to mark their chart somehow? We're exploring all these options, so that they can then call us. And then that's a point of, that's a nodal point where we can maybe recapture this vulnerable patient and re-engage them in treatment. Solutions, again, academic detail for our OB population. I really believe that we need to expand the number of MAT providers, and that means academic detailing, going out there on the pulpit and really having these discussions, using that data again that we talked about before. What are the important pieces of data? Well, we have data that we know we need to use for collection and for submission to the Bridge program and for the BHPP grant. Now we're talking about using that same set of data to address some of these issues. Well, what is it? Well, we don't have enough MAT providers. These are the number of high-risk OB that are coming through the system. How do we get them appointments? What are the next steps? And using that data, having key stakeholders and engaging for example, family medicine and OB, to expand some of those services. It can be done, and we've done it. It took several years, but it finally happened here at UCI at our FQHCs in Santa Ana and Anaheim. We finally have more providers who are X-waivered, who are now willing to provide MAT for our high-risk OB patients, and we have a clinic slot times that are established for us. So it can be done. So this is another potential solution. Now, I mentioned quickly leveraging assets. Really, really important, right? There's a lot of discussions that I talked about in terms of the possible roadblocks to implementing MAT 2.0 to our vulnerable populations. And there's a lot of potential solutions. Each one of these solutions and pathways requires time and energy. So again, really engaging your county coalition. I'm sure all of you are involved with your county coalition, engaging the people there and getting them involved. You're going to need help. The other thing to highly consider is this Vista AmeriCorps program. I don't know how many of you have them at your sites, but every year there are allocated Vista AmeriCorps volunteers, and these volunteers are absolutely phenomenal. They're usually on the younger side, somewhere transitioning between college and the real world, or college and professional school, and looking to make a difference. We have several at our site, and it makes so much of a difference for them. They can do all sorts of things. They can conduct meetings, collect data, get out there to the different sites, whether it's at homeless shelters and so on and so forth. But these are really, really important and valuable personnel that require a little bit of oversight and time commitment from whoever's supervising them. But you could have 1, 2, 3 different folks at your healthcare system who are supervising them and allowing you to expand some of these projects to the 2.0 level. Again, there are usually college students and public health leaning students in almost every area of the state, and engaging your local universities. I know it's easier for me given that I'm at University of California, Irvine, but certainly there are programs all over, and engaging in the local, whether it's a junior college or colleges in your neighborhood, figuring out what interest groups are there in terms of student interest groups. They're just really interested in getting to do something. They want a project a lot of times. Of course, it's going to be a little bit of time for you to reach out and recruit them, but once you establish that relationship, you really have a pipeline of energetic folks. Again, the other thing that comes to mind are capstone projects. And so for any of you who are in the world of public health students need to do a capstone project, and that folks reach out from all over the can be from all over the country and not just from California, but they need a specific project. They're usually getting a master's level degree, and really engaging them in doing whatever you need to do your 2.0 level work.
So thank you, BC, for talking about how to engage vulnerable populations. But we all know that there are inequities in substance use treatment, particularly when it comes to race. This could be a whole separate training on its own, but I want to share with you some of the work that we are doing at California Bridge. Over the last 40 years, the US incarceration rate tripled to the highest of any country. And much of this increase was due to the war on drugs, since arrests for drug possessions tripled. Unfortunately, these laws reinforce and ultimately increase racial disparities, despite the fact that white Americans and people of color use drugs at approximately the same rate. We know that arrest rates for drug possession are at least more than twice as high for Black people than white people. In 2009, 2/3 of people incarcerated for a drug offense were Black or Latinx, despite representing less than 1/3 of the population. So we also know that substance use treatment has not been provided equitably. For example, a 2006 study showed that 91% of patients receiving buprenorphine were white. Counties that had a higher African American or Latinx population had more facilities that provided methadone instead of buprenorphine. Why does this matter? Well, this disparity is significant because methadone is highly stigmatized. It requires patients to line up daily in a public space, and a lot of patients hesitate to participate in treatment because of that stigma. So what can we do? Number one, provide equitable services. As BC mentioned, we know that treatment is more effective if we can address needs such as housing, food insecurity, unemployment. We need to make sure that resources are equitably distributed so that there are options for different racial or ethnic groups and non-English speakers. And we need to be proactive, reach out to the community and ask, what are you doing to provide equitable services? Number two, we need to share the patient's stories. A lot of times in the news, we see that the stories of white patients with substance use disorder is one of being a victim to the pharmaceutical companies or their doctors that prescribed these medications when they were in pain, and then they got addicted to medications. Yet oftentimes the stories of people of color are different, told from a perspective of, they were born into a community of substance use and they chose this life. So we really need to change these perspectives and tell the stories as they are. Number three, advocate for policies that advance equity. And number four, collect data for health equity analysis. So in addition to the BHPP metrics, challenge your son to collect data on race, language, income, if they're pregnant, what kind of housing patients have. So here at the Bridge program, we built a diversity and equity committee this last year that is dedicated to understanding the inequities in substance use treatment and advance policies that reduce these inequities. So I wanted to share this upcoming webinar on April 19th about treatment, not criminalization, featuring some of our colleagues from the National Harm Reduction Coalition and the Drug Policy Alliance. The registration link is on the website and posted in the chat. Return on investment is a big topic. It's something that every hospital cares about because when you receive a grant or discuss building a new program, administrators want to know, why should we do this? What is the benefit to the hospital? Is the program sustainable? I want to share some of the ways you can measure ROI for your program. I personally believe the biggest value of the program comes from the Sun family. The Sun model embeds an advocate for substance use treatment in every hospital who conducts assessments for patients, introduces a patient to the MAP program, works to expedite outpatient follow-up, and serves as a coach for these patients. Some of these individuals are called SUNs, some are called behavioral health counselors, some are peer navigators, but their work has been the key to success for all of our programs. They help with ED flow, they improve patient outcomes and provider satisfaction, and improve community relations with the hospital and outpatient MAT clinics. More importantly, the SUNs across our programs have been instrumental in changing the culture around substance use treatment. So according to the National Harm Reduction Coalition, harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. So what it means is that these navigators are changing the stigma and moving past judgment to help any person that uses drugs achieve any positive change. Some of the ways they do that include naloxone distribution, harm reduction kits, needle exchange, and an invitation to come back to the hospital for treatment anytime. The Bridge program also offers a tremendous system value to our hospitals. It can improve ED length of stay with the evidence-based protocols that require no telemetry monitoring, no required lab testing. Most of these patients come through our fast track, are given buprenorphine, observed for an hour, and discharged with follow-up. It can decrease return visits and admissions. We've noticed a decrease in complications such as overdose deaths, cellulitis, endocarditis, etc. There are some programs and guidelines we provide on alternatives to opioids that ultimately reduce the opioid equivalents prescribed and help providers look up patients' opioid use on PDMP and help patients get follow-up and administer free naloxone to patients. So these are just some of the ways that the Bridge program can increase your system value. There's no doubt that this program has changed the lives of thousands of patients. We have a video here with one of our patient stories, but since we're kind of running out of time, you can watch this video on your own if interested. I think provider satisfaction goes hand in hand with patient satisfaction. So we have all seen that patient who has chronic pain or opioid use disorder, who's actively withdrawing in the ED and just disrupting the care of other patients, or really harassing your nurses and providers because they're not being treated sufficiently. So by providing guidelines for clinicians and getting these patients treated effectively, I think the program helps reduce compassion fatigue and burnout amongst providers, which ultimately reduces provider turnover. Financial sustainability is a topic that all the C-suite administrators care about, right? How can we make this program sustainable in the long run? What happens when grant funding runs out? So I wanted to go over a couple of pilot strategies and the new billing code that got launched in January. So SBIRT billing, which is screening, brief intervention, and referral to treatment, is currently billable in inpatient and primary care settings through Medi-Cal, but not the emergency department yet. Health plans can choose to reimburse for it voluntarily. So as a program, we're advocating for this to be a Medi-Cal covered benefit. Billing drug Medi-Cal. So the drug Medi-Cal system is a voluntary pilot program through DHCS that offers California counties an opportunity to expand access to Medi-Cal members with substance use disorder. So the goal is to demonstrate how organized SUD care can improve health outcomes and decrease system-wide health costs. UC Davis is currently piloting the strategy to see if it's something that California and Bridge can encourage other hospitals to try. If this goes through, the change would probably happen in 2022 and facilitate reimbursement for services provided in the ED. Medi-Cal administrative activities claiming is a strategy mostly applicable to county-run hospitals. So certain counties can receive federal reimbursement for services provided to help patients access Medi-Cal services, which could include some of the services provided by the Sun. Contra Costa County is currently piloting this strategy. Obviously, the big one is the new billing code that is now available for MAT initiation in the ED. So let your providers know that for Medi-Cal patients, they can build this procedure and generate RVUs from it. We are also working with counties and health systems, insurance companies to see if there are other options for sustainability. I know that Dignity Health and Kaiser systems are already talking about building this program into their budget even after the grant ends. And of course, there's the option of renewed state funding, which is always a negotiation and we hope to attain. So now that we have talked about ROI, I want to share some strategies on how to communicate success of your bridge programs. So hospital sons champions deserve recognition for their work, and administrators love hearing about recognition of their hospital. So there's some ways to do this. Some hospitals have a media department that can write an article about the program. Some have a monthly newsletter that can spotlight the program. We have seen so many amazing interviews and articles published about bridge programs across the state. Over the last 2 years, many of our hospitals have made it onto the Cal Hospital Compares Opioid Honor Roll. Some of you asked how to apply for this, so I'm just briefly going to go over it. So Cal Hospital Compares is a nonprofit funded program to support quality improvement and recognize hospitals for their contributions to fighting the opioid epidemic. There's 4 elements to opioid safety that they look for. Number 1, prevent new opioid starts. 2, identify and treat OUD. 3, overdose prevention. 4, culture of opioid safety. So, all of our bridge sites are doing these things and should qualify to be on this honor roll. In the last year, 53 hospitals were recognized for meeting performance standards in opioid care, and you can take a look at the news article from this QR code. And in order to apply to be on the honor roll, they offer an opioid management hospital self-assessment scoring tool. It's something that you can fill out yourself and submit to the program. And in the next slide, we'll go over the quick timeline. So this year, they'll offer webinars and resources through December. And then the opioid management self-assessment will be available to hospitals in December 2021. The deadline to submit to be on this honor roll is March of 2022. So we would love to see all of your hospitals on here. All right, so now that we shared all this information, how do you communicate success with hospital stakeholders? BC and I have a quick little role play. That's why I wore the blazer today, just so I could be his CFO. And then we'll open it up to any questions, all right? So BC, hey, good to see you. Remember me, your friendly CFO. I heard we received a BHPP grant at this hospital. How does this benefit us? Why should we do this?
Yeah, Dr. Zhan, really thank you for meeting with me today. I know your time is really valuable, but listen, remember all of the medication-assisted treatment program that we started a long time ago? Well, I wanted to tell you, number one, we're on the opioid honor roll 2 years in a row. What does that really mean for us? It means that we're kind of the forefront in our community and in our county to providing excellent care for all patients, specifically with opioid use disorder. We did get that BHPP grant like you were talking about. And in that time that we got that grant, boy, we have served hundreds and hundreds of patients. We've served them in the hospital system, not just in the emergency department, but throughout the hospital system. As you know, some of that system has grown, and part of our hospital system's growth in the community is a key strategic function. And so we think providing a holistic amount of care, including medication-assisted care and opioid use disorder, would be phenomenal, especially for our new sites like at the FQHCs in Santa Ana and Anaheim and other sites. And I think this has a lot of growth potential and can give our hospital system a leg up in its marketing and in its value to the community. So as this role, as the BHPP grant is sunsetting, we would really love to have some of those sustainable resources that are in the future to help us continue this very valuable project.
That sounds promising, but a lot of patients with substance use disorder are uninsured or have Medi-Cal. I'm just worried that this population is not a good payer mix for the hospital. Why should we pursue this financially?
Well, number one, what we have been able to show is a number of wonderful things. In the hospital setting, especially in the emergency department, these patients are going to go to the hospital no matter what. And so these patients have we've decreased the length of stay of these patients, and we can show that. Where before, where we didn't really have treatment, or we had treatment such as clonidine and kind of symptomatic care, now we have really effective treatment, buprenorphine, as you know, and it has reduced the length of stay in these patients drastically. Not only that, patient satisfaction has gone up, provider satisfaction and nursing satisfaction is through the roof. So really, we've done a fantastic job there. We've decreased the number of visits overall that these patients are engaging in the hospital system. And that's one thing. We want to keep these patients healthy. We want them to go to services at the appropriate time and setting. And the emergency department can be an expensive service. And as we are open 24/7, 365 days a year, and we don't discriminate who should come, we do want to make sure that patients are served properly, that we bridge them and link them with care to the appropriate setting. And we've done that. We've done that, and that data that I just shared with you a little bit earlier in that PDF file shows that. So not to mention that Medi-Cal actually reimburses for this. And we just implemented in the last 2 months a pilot project to start coding and billing for these services above and beyond just the visit, for the brief intervention and treatment services that account for a moderate but significant reimbursement per patient seen. So really feel like beyond the monetary reinvestment, that it provides such a tremendous amount of opportunity for our healthcare system to engage in.
Wow, you're quite the salesperson. I guess, yeah, it sounds like a good program. What can I say? So now we want to open it up to our participants today, see if you guys have any questions, if you have any other ideas. Before we do questions, I just wanted to share with you our upcoming talks. There's a webinar on treatment, not criminalization, on April 19th that we mentioned earlier. There's an innovations in nursing training coming up on May 25th. So please invite all of your nursing staff. And we will have a next Be the Changemaker training in May. More details to come about that. All right, so what questions do you have? Thank you guys so much for your time today.
Hey, Jen and BC, I'm seeing a couple questions from a little bit earlier in the session. With a new MAD initiation in the ED, I know patients have limited time they can use drug Medi-Cal in a year. Does this billing count against them? Can either of you speak to that? If there are billing questions we need to look into, we can do that as well and follow up.
Yeah, I think the drug Medi-Cal billing is still a pilot program, and we're not yet, doing that with buprenorphine. So we'll look into that and get back to you. And this might be something in 2022.
Yes, that's my understanding as well. And California Bridge is doing a lot of work in exploring how the drug Medi-Cal space is working for a few of the hospitals that we work with who are experimenting with that. And in terms of private payers being a consideration for reimbursement opportunity, Tammy, yes, that's another thing that California Bridge is exploring via our sustainability work, is whether partnerships between private payers and hospitals to make this work sustainable is possible. So we're hoping to have a lot more to say about those topics and more in the sustainability space later this year. What else? What other questions do people have? You're welcome to raise your hand to speak or to put questions in the chat. BC, what's up?
Just to add on to that, I would say one thing, that if we don't start recording, and data is really important, if we don't start recording and even considering documenting and billing for it, no one's going to reimburse this. I look back several years ago when smoking cessation was a big a push for us to start documenting, and the counter argument, which is valid, is why waste all this time in teaching our providers and our billing and coding folks to start providing, start implementing a change in the way we practice. Well, now that's all reimbursed. And once it starts taking a foothold, as one or two insurance providers start kind of opening up that opportunity, others have, they want to kind of meet that standard of care. So I would say it is going to be choppy the way all of this gets reimbursed. But if, number one, if we don't start recording it and asking for it, you're not going to get it. And the reason for asking for it is, again, a return on investment, so that you can argue, if you can persuade your C-suite, your chief financial officer, to commit to some resources that make a difference. And so I would say take that plunge, because that return on investment is will be there. It just might take some time.
What else? We have time for another question or two. John, are there any questions that you want to bring up that you answered about data collection? If you want to go off mute and pull anything up, I saw you answer a couple questions in the chat. Anything you want to pull up?
Yeah, just a quick review that if you haven't hired your son yet, you can still report, and you've received your funding, you can still report the non-son specific metrics like overdose diagnoses, OUD diagnoses, MAT prescriptions and administrations. And that is all linked in our BHPP overview portal. So.
And here's a good clinical question while we have clinical experts on the training. You mentioned that it takes 1 hour for providing BUP in the ER and discharge. Is this time frame sufficient? Do patients leave the ER with a script with a prescription for BUP, Suboxone, or several doses? That's in the Q&A if you want to take a look at it, Jen and BC.
Yeah, absolutely. I think the time frame for each patient is variable and it's patient dependent. You know, our protocols recommend giving a dose of BUP and then observing for about an hour until the buprenorphine takes its peak effect, and then seeing how the patient feels. You know, if they feel better and they want to go home with a prescription, most of our providers are X-waivered. They can do that. We have a naloxone distribution program now, and the son has a spectral link, so it's a really quick consult in the hospital. So the whole process is very smooth and fast. Oftentimes the patients know what their home dose of BUP is, or they've been on it in the past. So they'll tell you, hey, this works for me. Of course, there are patients who are new starts and need some more observation time to get their symptoms under control. But for, you know, uncomplicated opioid withdrawal, most of the time they don't need any labs or imaging or, you know, telemonitoring. So it can be done in quick track, fast track. The PAs can take care of them as well.
Yeah, the average length of stay for most emergency department patients in California is about 4 to 4.5 hours. When you talk about opioid withdrawal in the traditional sense and putting an IV in and a patient that may or may not have good IV access, and then kind of treating symptomatically with clonidine and ondansetron, compazine, you name it, fluids, that lasts easily 4 to 5 to 6 hours and frustrates the heck out of everybody. This will cut down your time at least in half. Everyone leaves pretty happy. It is obviously a cultural change. And if at all possible, that's the whole part about this bridge program. If we can send them home on a prescription and a link to outpatient clinics in your neighborhood, that's phenomenal. And that's exactly the goal of all of our hospital sites that are coming on board. So yes, absolutely. And you'll see, you will quickly, even the strongest naysayers will come on board and will love you for it.
There's a question about making contact with parole officers or other community contact points for marginalized populations.
Yeah, I mean, again, this is MAT 2.0, and or maybe even beyond, but I think it is our goal. We have certainly made contact with our prisons and our medical director in the prisons, and he is completely on board. There are challenges as to the next step. So we are focusing on using our our contacts in the criminal justice system to see how we can engage the parole officers. So that's kind of our next step. And we will report back to you as to how that goes as a opportunity to continue the contact that we hopefully have made for these patients who have already been released from jail. So I can report back to you in a couple of months on that.
And Ashlyn, just a reminder that our Sun Mentor team is standing ready to help you understand how to do outreach to all populations, including justice involved populations. We have people who can coach you on how to even get started because we know it can be scary. Awesome. Well, we are at time. Thank you, everyone. We are here for you. So you look for a follow-up email with this recording, which might be useful to share with anybody involved in the data and evaluation pieces of your program. And we hope to see you very soon. Thanks. Yeah, thanks, everyone. We'll keep it, this open for about another minute, just in case there's any final questions, and then we'll go ahead and end the recording and the session. And thank you as always to our communications team for making these smooth and seamless. Oh, that's right. Here's your CME link. Thank you, John. That's your CME link. That'll go out in the post-event recording as well, or the post-event email as well, to get CME for this session.
Thanks for joining, everyone.
Thank you. All right, Caroline, I think we can go ahead and close.